whatever reason, it wasn't thought through properly, or the nurse wasn't prepared, or I don't know. But sometimes I've had the experience where you put the NG tube back in and the patient says, "You're done? It's in?" And so you know there's got to be a little bit easier way. Now, in my opinion, it's going to be kind of red no matter how you put it in, but we'll do the best we can to make it easy. The other thing, and in 35 years, this is the first time I've ever seen this happen, when you put an NG tube in, as you know, it's very easy to put it in someone's lung because they're breathing and swallowing and everything all at the same time. Well, in my experience, putting an NG tube in somebody's lung, they turn purple, red, blue, they cough, they have tears, they're like freaked out, they pull it from your hands. And you know, oops, sorry about that. Okay, let's stop in the group and start again. There was a woman in room 22, now it's probably 18 or something like that. She was 94. And her name was Elizabeth, and she came in through the ER with bowel obstruction. They put an NG tube in. She spent the night with us, went for small bowel follow-through the next morning. And when they do a small bowel follow-through, they do a scalp film to check to be sure where the tube is before they put gastrography down, right? And her x-ray looked like, if you turn your page over, it looked like the one on the bottom right. See how it goes down to the carina there, where the esophagus and the lung tubes split out, and then it goes over directly to her right side. And except it didn't look like this cloudy spot because, thank goodness, they do a scalp film first, because if they had put gastrographing down this tube in this woman, it would have killed her probably. 90-something years old. Gastrographing doesn't belong in your lung. The interesting thing is, so the nurse caring for the patient came to me and said, "Oh, Carol, I need your help putting an NG tube in." Okay, fine, I'll be happy to help you. Well, it's in her lung. I said, "There's no, is she comatose?" Because I've never put an NG tube in a lung where the patient hasn't turned every color of red, blue, purple, and everywhere in between, coughing, spitting, swearing, drop their oxygen sat, the whole 9 yards. This woman comes up from x-ray, and they had actually removed the tube down there because they realized it was in the wrong place. And I'm like, "God, she's awake and alert. That's pretty weird." So I pulled up the x-ray myself because I said, "There's no way." Well, sure enough. So we put the tube back in the right place, and she said to me, "You're kidding, you're done? You did that? It's in? Why didn't that hurt?" Well, I'll give you some tricks. And the other thing she said was, "Did you get the right size tube?" And I said, "Well, it's the same kind of tube that was in before." She said, "No, they told me downstairs that the tube was the wrong size." I said, "Well, no, actually. The truth is, the tube was in the wrong place." And so I had to take it out. So now it's better. So the clues would have been, well, first of all, normally the patient is coughing, so, you know, I learned something even after all that time. Be careful, because had the nurse, her nurses, there were a couple before that, before we discovered where it was, who might have looked at the tube and went, "There's nothing coming out of this, I better irrigate it." Well, what if you shoved 30 cc's of water down a tube that was in somebody's lung? That would have been a disaster in and of itself. May not have killed her, but the gastrography probably would have. Yet there was nothing coming out of it, and the patient was vomiting, despite having an NG tube. Well, you just have to think through it. Why, if they have an NG tube and it's placed in the stomach and the suction is working, why would you not get something out? If nothing else, the water that she drank to swallow the tube, right? Anyway, so there were some clues, but fortunately nobody investigated it too thoroughly, because had it been me, I probably would have put a little water in it to see if it was plugged, and that would have been a disaster too. So anyway, I think about Elizabeth when I put an NG tube down. Found another gentleman on the other side not very long ago. Some nice nurse patient was all bloated up, and I thought, he's going to end up with an NG. Sure enough, I came to visit him the next day when I worked on the other side, and he had an NG tube in. This much of it was hanging out of his nose. I'm like, wow, where's that tube? So I got another tube, measured properly, and I pulled out about a foot of it. So I don't know where the tip of the tube was. Could have been down the duodenum, could have been into the stomach and coiled back up into the esophagus, for all I know. Could have been tied in a knot. That's happened too. So we want the NG tube in the stomach. We want minimal trauma to our patients, and we want to decompress their stomach is the reason we put most NG tubes in. So does that cover the S bar? I'm not really going by this. Types of tubes. Okay, I'll go next to that. At Providence, we mostly use these two kind of tubes. This one is an Anderson nasogastric tube. We know an Anderson because it has a little yellow doodad at the top, and it has a stylet in it. I'll show you that in a sec. This is a Salem sump. This is the other kind. They're both made for continuous suction. They both are vented tubes, so that you put it to continuous suction, there's an air intake so that the tube floats in the stomach and doesn't suck up against the stomach wall. In our paperwork, there's also a Levine tube listed. I haven't seen a Levine tube used in a long time. If you should have a tube that has no vent, it must be to intermittent suction, or you will suck it up against the stomach wall and cause irritation to the gastric mucosa. Okay? So let's look at the Anderson. Not my favorite kind of tube. Some people really like it. Some doctors really like it. Dr. Friedman, I think, prefers this because he feels it's more comfortable to the patient. It comes with a connector already in the package, and it fits well. I don't like them because I find them hard to place. And I also find this stylet very hard to remove. Sometimes it's really stuck. So before you place an Anderson, make sure you take the stylet out and fiddle with it a little bit, okay? And make sure it's back in the right place before you start, and that it's all the way in the tube. Once you pull the stylet out, after it's in the patient, you cannot put the stylet back in, just like a feeding tube, because the stylet could go out one of these holes and poke a hole in the patient's stomach. So don't pull the stylet. Once you pull the stylet out after placement, don't put it back in. But do take it out before you put it in the patient. Make sure it's loose enough. And sometimes I put a little lubricant down here and on the tip of the stylet so that it'll be easier to get out. Now, I have put this all the way in the patient. Then I have it up here, and I'm pulling it out, and I'm trying to pull it out, and trying to pull it out, and it won't come out because my fingers are so tight right here because I don't want the tube to fall out, that I have actually pulled the stylet in half and broken it. I had to pull the tube out, so, you know, lighten up a little. But I've also had stylets that have been so stuck that I can't get them out. So
I was going to say, Carole, it's always been my experience to leave that stylet out a couple of inches, not all the way back to the end of that tip.
Well, no, that might be a good thing.
Yeah.
So long as you're not tempted to push it back in if you have trouble.
Yeah, but because I think if it's all the way in, several
it's too,
other, you
too
can't
tough
get
right
it out.
here.
Well, you can't get it out.
Okay.
And the last thing you want to do is tell the patient,
sorry, I've got to take it out and start it. Yeah.
So I've always left it back a couple of inches, and I've never had a problem getting that stylet out.
So the reason for the stylet is that the tube, this tube is very bendable, okay? And so if you don't have the stylet, it's easier to get it in the wrong place. So that's what has to have a stylet, because it's too flimsy. For me, it just seems like the Salem goes in the right place more often. Some people feel this is a little bit smaller than a Salem. The part I want you to pay attention to, you can feel that it's got these ridges where the holes are, and feel how that feels compared to how this feels. And you'll realize that you want, when you're putting it in the nose especially, you want this smooth part across the top of the nose or across the, the bottom of the nose so that your ridges go sideways. So I'll pass this around, you can take a look. The care and maintenance of it once you get it in is the same as the same. And then it has a little smaller connector Christmas tree that works really well for it because it fits.
I have a question. And then typically, once it's placed, they would have an X-ray, and once it's verified that it's in the right place, they take out the stylet?
No. Generally, you can verify placement by injecting air and peering it, hooking it to suction and getting green stuff. Now, if those two things you have any question, then I would call the physician and get an X-ray order. But it's not protocol or policy to get an X-ray on every patient. If you don't get the expected results, then yes, I would call for that. But in general, if the patient has a stomach full of green stuff and you hook the NG tube up and it all goes in the bucket, there's your evidence.
And the dog pop feeding tube.
Yes, exactly.
The wire in, and it goes down.
Yes, you're right about that. Sorry, that's a good clarification. Yeah, it's the feeding tube that you must have. And that's a whole different, education. The dog pop placement and the 10-10-10 protocol and all that, different animals. So a Salem, as you can see, it is a little bit bigger. The holes are a little bigger. So if you have a patient who ate a lot before they got obstructed and they've got salad in their stomach or something, you're more likely to get it out with this one than you are with that one, because the holes are smaller and it plugs up easier. And again, though, if you feel this is really kind of rough. So you need to be careful how you're putting that in, because these are, rigid plastic things. Some people like to put their NG tube under warm water to make it soft and pliable. Some people like to lay it in a basin of ice to make it firmer. Do whatever you want to do. I just stick it in the light and off I go. But, it hurts and it's hard to get in no matter what, but I kind of like to put on this one, the holes are on one side, here and here, and not so much on the bottom. So I kind of like to do it so that it folds, the holes fold naturally this direction. Okay. This one has a nice little connector too, but I don't like it. It doesn't, and it's hard to get off and on. Once you put it on there, you're forever and it flies all over. So with this one, I replace it with a Christmas tree. This is a Christmas tree. So that's what I was saying.
Carole, just as a side note, I have ordered the Salem. We usually have 18s on the floor. You get a petite person concerned about the size, you want to use a Salem, order that to 16.
Oh, you can? I didn't know we carried that.
Yeah,
Okay. Okay, very
Say
good.
that again, Anderson?
This comes in a size 16. This is an 18 French.
Oh.
You carry 18 is kind of the standard, and if you want a
Very
smaller
small.
tube, let's say you got that little 92-year-old lady that weighs like 80 pounds.
And her
it's
nose
just
is about
a
this
petite little
big.
thing, always has been. And sometimes with 18 in Salem is a little invasive. And it's a big tube.
It is good size.
But that's why it's effective. But I have ordered them in 16, and they go in and everything's the same. They're just the
A little bit
diameters.
small. I didn't realize we carried it. And you may, the way they're changing the Epic ordering and stuff, you may have to call and ask them.
We actually have a pediatric 10.
A pediatric 10 is
But
a
it's
Salem?
not listed, it's a Salem, but it's shorter, so you have to make sure that it's long enough. But I have just at least quite a few of those, on those little petite 95-year-old ladies that have a little nose. So, but you have to ask them to supply for them, they're not listed in our system.
Thank you. Okay, so that's about the types of tube. Now, first of all, let's cover, I'm going to hurry up, sorry, I could go on forever. You put an NG tube in, most of the time we do it is because the patient has a bowel obstruction and their stomach is full of green stuff, or they've got an ileus and their stomach is full. If you ever see, and if you ever have a question, please ask your buddies. If you see the diagnosis of hiatal hernia repair, fundoplication, gastrectomy, esophagogastrectomy, duodenopectomy, anything that has gastro, duodenal, esophageal, anything upper GI in the diagnosis, and that's their surgical admission, this is not your job. This would be the surgeon's job, okay? Now, if it's been 10 years ago and they had a miss and fundoplication, it might be okay. But do not replace an NG tube or place an NG tube on a fresh post-op gastric surgery, upper GI surgery yourself. That would be the surgeon's job. Because
last year, like Dr. Hughes, before he took away his book, mentioned something about in the last year.
what happens is the suture line where they connect things in there, especially in the upper GI tract, is very fragile. And this tube could go right through the suture line, and that would be a disaster. All right, so just to cover that, if it says anything like that. And if you don't know why you're putting an NG tube in, ask somebody. Ask a friend, because that's a good question. If you don't really know why you're doing it, make sure you've got a good reason, because this is not a very fun thing. Okay, a couple words about measuring the tube. The best way I know how, and the way I do, and actually something I read said to use the bottom of the ear, but I always use from the tip of the nose to the top of the ear. So start there, and you see that you're at about between 15 and 20 centimeters on the tube, okay? And I don't know how the Anderson is marked. It might have different marks on it, I don't know. So if you need to, take a marker and put a mark on there, okay? That's going to be your stopping point when you get it through the nose. It's your first measurement, top of the ear to the tip of the nose. And that's right before you're going to make them gag. Okay, so you stop there, let them rest, regroup for a second. And then your second measurement is from, so here's your first one, top of the ear to the tip of the xiphoid process, right about there. And if you pass this tube around and look at everybody in the room, everybody will be somewhere between 55 and 65, okay? Every adult person. So if you come into the room and the patient's got the tube this far into their nose and only this much hanging out, you know that it's too far. I've never put it in. 65 is probably generous. I don't know. That sounds generous to me. 60, 55. Okay, I'm tall, but that's fine. Yeah, 60, 61, okay? 55 to 65 is just about, and that's when you know you're in the stomach, okay? And so then I'm going to demonstrate, okay, let's also set up suction. So that's the other thing. And sounds like we're going to be doing more of this. And I'm sure most of you know this. Our suction, we have a suction head on the wall, right? There's one on either side of the bed on the high side, low side, at least one, sometimes two on the high side also. And there's a gauge that we didn't bring in here. Some gauges at the top of the box, there's a little switch up here. If you're not very tall, it's hard to see. Sometimes there's a little switch on off. Then sometimes on the front of it, there's intermittent continuous like that. Okay. So set up your suction ahead of time. This goes into the bracket on the wall, like that. This is attached underneath here in this little white thing. Notice you also have an on-off switch on the back of your suction canister holder. So if this is off, you won't get suction. So turn that on. Here's your wall. Can you see the wall? The wall. Okay, and this one doesn't have a doodad at the top, but it has the things in the front. So this goes on here. And that goes into the wall. And if you turn this on to continuous, and you turn this up and nothing happens, you've got a problem with your gauge and the way it's attached to the wall. Sometimes if you're not very tall, getting the gauge seated into the wall is harder than you think. So the best way to do it is pull it all the way back towards you this way and push it in level. And if you're too short for that, find a friend.
Just like this, these fins here are worn down, and you can put pressure on it and suddenly it works, and if it doesn't work, just replace the page.
So you got that one, and this is hanging on the wall. Then the liner goes in here. This is the same liner for all of our sections that we have. And then you got all these choices. This one says vacuum, and that's where the red hose goes, in the vacuum, okay? Because this is your vacuum. There's a tandem, but unless you've got two suctions going at the same time, we usually don't use that one. So cover that one. And then you've got this one that says patient. And that's where this tubing goes. And that's the long suction tubing.
Remember that patient I had in hospital on my side where I was doing the suction? And what was going, there was
The valve inside. So then you hook this to here. Sometimes you'll see that people have removed this. That's okay too if you want to. Just stick it on like that. Or use the little. Now, one thing, and then it comes with this little connector. That's pretty much where it is. That has to. So that's where your Christmas tree goes in there. But just leave that set up until you're ready to put it in the patient. Now, this thingy right here is how we empty the bucket. We don't mark the container at the end of the shift. We take the cap off, put our glasses on, and empty the bucket. Now, if you empty the bucket like this, the bucket empties here, this red thing is here, right? So the suction happens underneath this red thing. Inside the container there, underneath the red thing is a check valve that sucks up in there if fluid gets in that area, because we don't want green stuff going up here and into the wall, right? So when I empty, first of all, you want to empty off the lip as close as you can to the edge of this, and I usually break that suction so that there's no suction going on, and you empty it there. Because if you come in this bag, see how it's kind of wrinkly in there? If this bag is all blown up like a balloon, and you pull apart your NG tube suction right here at the connection, and there's no slurping sound, then something's wrong with your suction, regardless of what the needle says. Because the needle will go up, but you pull it apart and there's no suction. And this is all blown up like a balloon. You need to take this blue thing out, replace it, start again.
Carole, when I empty, usually I just take the whole insert out and just connect.
You can do that too,
Good.
sure.
Doesn't matter? Okay.
No, that's fine too, yeah. And as long as you're breaking the suction and then opening this thing. Okay? Does that make sense? Okay. Thank you. Okay, so if you have an NG, we've got these extra doodads. Salem Sump anti-reflux valve, these are in our stock. So if you come on and this thing is all green and nasty and there's stuff coming out of it and the tube is full of green stuff, you can take this off, inject some air into here, and replace this with a new one, and that will be better. Because once the filter inside here gets all wet with green stuff, the air doesn't suck back through here, which is the way it's designed to do. When you have this at your bedside, the tubing, and it's coming from your patient, and it goes down over the railing, down to the floor, and all the way back up to the suction, that's not going to work very well. The suction isn't that strong. You want to coil it up, stick some of it over top of here so that it's kind of more in an even line. You don't want it so short that the patient's going to get, stuck, or put a coil under their pillow. Okay. This tube especially is designed to whistle when it's working. So if you hear a whistle through here and you make that stop, and you're like, what is the matter with that? I gotta quit that. And I'll come in and find a calf plug in here. That would stop the whistling, but that's It says right on the package somewhere here, if it's whistling, it's working, or it used to say that right on the front. Anyway, the whistle is the air going in, replacing the suction which is going out, okay? So don't stop the whistling, just put it under the pillow, whatever. Okay, now we're gonna put an NG tube in this guy, and then he's gonna be around for all week, and you can play with him. And I'm going to pick a friend. So here's the most important thing about all this stuff you've got here. You've got the suction, you have the syringe, blah, blah, blah. The most important piece of equipment you have available to you to put an NG tube in is your Zen friend. And I'm going to pick Mary because she's my Zen friend, and we've worked together for like ever. And we're going to meet Larry's going to get an NG tube today because he's been vomiting, and the x-ray showed his, small bowel is all full of air and his stomach is distended. So Mary, will you come in and help with Larry? So we're just going to pretend like we're placing an NG tube on Larry. Now, Mary, I've got suction set up over here. And I want you to keep track of that and make sure it's turned on properly. Larry, this is my friend Mary. We've worked together for years and we're friends, and we're going to put this NG tube in. And it doesn't sound like a very comfortable process, but we're going to do the very best we can to make it comfortable for you, okay? The first thing I'm going to do is put some lidocaine in your nose to numb it up. Lidocaine requires a doctor's order. So be sure to ask for that when the doctor calls and gives you the order for lidocaine. Okay? Mary, we're going to put some gloves on, which I don't have with me. Okay? You have gloves? And here's some goggles for you. Goggles for me. That's kind of important, because sometimes, yeah.
I love it. Somebody's already using the goggles.
and I want you to have. Gosh, that's going to be fun. Okay. And I want you to have this little towel on you, and Mary's going to help you hold this bucket in case something happens while we're putting the tube in. So let's start with the lidocaine, because it takes about 2 to 3 minutes to kind of kick in. This is a Eurojet, commonly used to put in a catheter mostly on a male, right? And it works very handily for NG tube placement because it happens to have the right shape. Pull this off and that happens to fit right in the nose. So Larry, have you ever had a broken nose? No, you haven't. Okay, if you breathe in now, tell me if you feel like one side is more open than the other. Oh, this one's better? Okay, we'll try that one first, but I'm going to numb up both sides just in case, okay? Now, you want to be careful with this. You don't want to put too much down because it'll make them gag, and then their swallow is kind of anesthetized. Sorry, I have to. Their swallow is a little bit anesthetized, so you really only need about 1 cc. 1 cc in one side of the nose, 1 cc in the other. So Larry, I'm going to put 1 cc in your nose, and I want you to breathe in. There you go, there you go. Okay, feel that? Oh yeah, you can taste it. That's kind of nasty tasting, but it'll help your nose get numb so it doesn't hurt to put this in. Okay, we're going to do the other side now. Okay, I'm going to put in 1 cc, breathe in. There you, oops. I really need to give me, sorry. Sorry, Larry. It's probably not best for your plastic nose. Okay. Okay, so then I'm going to take some more of this, put it into here. I'm trying not to use this twice, so we do this again. And then I'm going to take the end of my tube and lube it up. But while he's numbing up, I'm almost ready, Mary. And I've got tape here for you, because that's what I like to use. And I've got, this is an NG tube strip holder, which I'm not fond of them, but you do whatever you want with your own practice.
Are you comfortable on that side?
Oh, I am right-handed, so I like to stay on the right side of my patient because it just seems more natural to me. Some people, if they're putting it in this nose, they want to be on that side. Some people, if they're putting it in this nose, want to be on it. You do what you want and put your buddy on the other side.
So I'm gonna tell Larry, just listen to Carole the entire time. I'm gonna have this glass of water, but until Carole tells you to start sipping it, I'm not gonna give you any of this to drink.
So first I'm going to measure, Larry, so we get the tube in the right place. So I'm going from the top of the ear, the tip of the nose, and I'm just a little over 15, right between 15 and 20, just like on my own self, okay? Then the top of the ear to the tip of the xiphoid process, which looks like it's right about here. 60. Pretty close to everybody else, okay? Okay, Larry, I think we're pretty much ready. Mary has that. We've got the suction all set up. We have a syringe ready to go because we're going to need that to check placement. I have my stethoscope on, and that'll help too. Mary, I might need you to kind of keep track of that for me too. Okay, Larry, the hardest part I find, glue, 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 and Larry has his own glue, so I'm going to do his own because it's consistent with his nose stuff. So that's lidocaine on there. Or you can use regular old, is fine if you want to. If the patient's allergic to lidocaine, that lets that out, right? Okay, and I'm going to put the end of my tube into the bucket. Okay, Larry, I want you to lean your head back just a little bit, and we've got you in a very upright, high Fowler's position because it seems to be easier to place a tube that way. And in an ideal world, I would raise his bed up some more because I want him to be right about my eyesight, okay? I'm going to tip your head back. If you look at your picture on page 2, see how the nose has a flat part? People tend to want to go like this, right? Go straight up. What are they going to hit? That flat thing right there, right? And that hurts. That hurts like heck, okay? I want to go level as best I can because that's going to be easier to get down. So I have Larry put his head up, look at the ceiling, and I kind of push his nose up like a little pig, like that, okay? And that's going to make it go in straighter and down to the back. And remember, I'm going to go till about 15, and then I'm going to stop for a second. So Larry, let's tip your head up. Oh, that's pretty heavy. Okay. A little stiff, but anyway, you get the idea. Okay, and then I'm going to push your head up with my gloves on, and there the tube is going to go to about here. Oh, beautiful. You did a really good job. That's great. I know, I'm going to wipe your tears. Oh, and I used the wrong side. You told me to use the left. I used the right. Oh well, it's in there. And sometimes the side that the patient feels is clearer is not the one that's easy to put in, okay? Larry, you did great. Okay, that's really the hardest part and the most painful part, and you just flew through it. So now what I'm going to have you do is tip your chin down and look at your belly button. And keep your chin nice and tight to your chest, okay? See the belly button down there? Good job. Now, Mary, if you can give Larry some water to drink, okay? And I want you to take a swallow of water and swallow, 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 swallow. Once he's started to swallow and you can tell he's swallowing, go, 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 go. Okay, once he's past this, if you start here and the patient, you know, he's starting to retch, pull back just a second, let him vomit if he needs to, regroup a minute, say, okay, we're okay. Try not to pull the whole thing out again because you're just making it worse by having to put it back through the nose. They'll want you to take it out, but you want to just relieve the gag for a second, let them regroup, and then start again. Once they start to swallow and you get it past this right here, can you see the, let's see, okay, if you look at this thing, this is the esophagus back here. This is the part that goes to the lung. See how close they are? You can, I'll pass this around. When the patient swallows, this closes in the front. So this goes down here, and the tube goes down this way instead of going into the lungs, okay? So, but they're very close together, so you can see how it happens. having them put their head down and look at their navel and swallow exaggerates that curve so that it goes more smooth. So pass that guy around. Now, unfortunately, even in the sim lab, every time I tried to do this, I put it in Larry's lung. So his anatomy isn't as good as a human. But anyway, so we go until we get to 60. Okay? Now, Mary, would you hook up the suction real quick? So pretend this is 60 right here, and I'm holding on. And I'm saying, you know, Larry, you did a great job. Here's a nice full washcloth. You're doing okay. We're going to check this out. Oh my gosh, look at that. Wow. Yeah. No wonder you've been feeling so sick. I'm so sorry. And you know what? This is going to make you feel so much better.
Oh my God, Carole, look
wow.
at this.
Sometimes NG tubes are really worth it, aren't they, Mary? Okay. Mary, would you hold on right here now? Because I'm going to check placement once I got most of the green stuff out. I'm going to take that apart, and I'm going to put about, I don't know, 20 or 30 of air right in here. And I'm going to take my stethoscope and put it right at the top of his stomach, right here. And I'm going to go, oh, that was a huge bubble I heard. That's right. Now, you do that and the patient belches, the tube is too high up here, usually. Or the tube has turned around and come back up the esophagus. So if you've got the whole length in, and the patient belches when you do that, it can be coming back up the throat. But if you hear a nice big bubble, it's usually in the stomach. And again, the proof is in the pudding. If this is sucking out green stuff, you're pretty much convinced you're in the right place. Now, I like to do the double wrappy tape job. You can use the doodad if you want to. I put this on the patient's nose. Make sure your tube is dry. Wrap it around. Wrap it around. Directions, put a little extra piece across the top. Then we take a little piece of tape like this, put it on the tube down this way, pin it to the shoulder of the nightgown so that in case we accidentally pull on this, we're not yanking on the patient's nose. Now, we're going to clean everything. And most patients are pretty gaggy when they first get it in. Reassure them that after a few minutes, this is going to calm down. When they get up to walk, this isn't going to get in the way of your walking. It's still very important that you walk 4 times a day, okay? And when you do walk, we're going to disconnect this from here, and we're going to put a yellow doodad in here. Now, one thing that I have learned over the years is if you fold this blue thing in half and stick it in the yellow, it'll keep the green stuff from coming up here when the patient is up and about and this is dependent. Because the green stuff is always going to take the path of least resistance. And once you get green fluid in this thing, it tends to goof up the air intake. So if you can protect that a little longer, that's good. Get back from your walk, hook this up, take that off, and go back to your suction.
I've seen in the past people,
Use
white.
this, yeah.
Please don't.
And I think that's the idea. But when that happens, usually you also see green going both directions.
And
it's
sometimes
gross.
it's like that plastic
Yes.
latches onto
And
it,
you
and
can't
people
get
have
it
actually had to have the extra tube pulled out because we can't get it apart.
Can't get it apart, or you
So
can't get
please
this
don't
off
do that.
anymore. So I don't
Yeah.
like to use the white. I think that's the intention of the design, but it doesn't work in practice very well.
Can you show us one more time?
Yeah, so put the yellow calf plug in here, which the first couple times is tricky because the tube is kind of tight, but it will loosen up a little bit. Then I fold the blue tube and just stick it in the back of the yellow thing, like that. Okay? That's why I like to use that instead of the white. Okay? Now, here's a word about, you ask the doctor for lidocaine gel for the nose. Be sure you order the Eurojet and ask them, could you put it in as Eurojet, or if you do it over the phone, whatever. Some doctors may say try lidocaine spray. be very wary of Cetacane spray. It comes in a yellow metal bottle. It has a long, skinny metal thing that you're supposed to put way in the back of the pig and then spray it. You need very, very little of it. And if you get too much, or the patient goes like that when you're giving it, can be fatal. So I'm not a fan of Cetacane. It makes their swallow numb, but it really doesn't help the nose that much. So to me, this is the part that hurts so bad, is in the nose. So I'm a big fan of lidocaine and not Cetacane. Cetacane spray is very dangerous, and they use it a lot. If they're going to put a tube in someone's mouth and go down their throat, maybe an endo or something like that, that's one thing. But yeah, used it once on a very anxious patient. Bad idea. He turned every color of the rainbow. And yeah, we never did get an NG tube in him. That was bad. I'm trying to think if there are other details. And again, when you come on shift, your job, Larry's got his NG tube in and he's had it for a while, and you're looking at it and there's a bunch of green stuff in here, and you go, well, I wonder if this is working. So you take your suction, the Christmas tree part. So he's all hooked up to the wall, and you're just saying good morning and how you doing. You unhook this right here and hold this up a minute so it doesn't pour green stuff all over everywhere. And this does not make a sucking sound. Chances are you've got a problem from here to there. So check your suction setup. If this is all doing okay and he's still quite nauseated and feels like, oh, I just feel so sick, take your syringe and put a little air into here. Oh, it was a little bit stuck. Okay, Larry, this is going to help. Hook that up, make sure the suction's turned on and going about 80, and it'll take off and treat you well. Okay? That'll make you feel better. It just wasn't quite sucking very well. And sometimes they're temperamental. Sometimes people get very fixated on them. They look at them and look at them. And the fact is, it's not going to drain green stuff every second. And it will sometimes get stuck in. Thank you, Mary, for your help. The other thing, let's see, I just thought of something. Oh, intermittent versus continuous suction. These two tubes were intended to be used for continuous suction. Okay. Some doctors like intermittent suction. If the order says use intermittent, use intermittent. But in the absence of, if it just says hook to suction, you want about 80 millimeters of suction on the wall thing here. So you're right between low and medium. Any less than that, and you really don't get enough suction to get the stuff out. Any lower or any more than that, and it's just too much to get the stuff out. Okay? Any questions? Sorry I took so long.
I have a request. You know,
Yes,
that little piece, that connector piece that you said this is useless?
Oh,
Ham on
Keep
it.
them for me for the Humane
Gotcha.
Society. We use them for suction for our abdominal surgeries.
here we go.
So,
So there's a use for everything.
Yes,
It's not
yes,
useless
I know I
here.
asked a lot.
Thank you.
Okay, you're welcome. Sorry to take so long.